Modern medicine has mastered the mechanics of keeping the most fragile infants alive, yet the development of their nervous systems has not kept pace with these clinical gains. Survival rates for extremely low birth weight infants over the last 2 decades show a steep, consistent climb. However, the proportion of these survivors who develop severe neurological impairments remains starkly flat and sometimes even rises. These neurological outcomes translate into significant economic shifts. Preterm births account for 74% of initial hospital costs, and the resulting educational gaps lead to an estimated $300 million in lost annual earnings for adults in the community. Advancements in neonatal care are highly effective at keeping tiny bodies breathing, but by focusing strictly on physical survival, medical science is inadvertently leaving the central nervous system unprotected. The transition from the isolated fluid environment of the uterus to the neonatal intensive care unit happens in an instant. The infant brain operates on a biological principle called experience-expectant plasticity. It relies on specific environmental inputs, delivered at precise developmental windows, to build its structural foundation. While a preterm infant's brain might look anatomically complete on the outside, its internal wiring, the intricate network of dendrites and synapses, is completely exposed and actively forming. The NICU is not a neutral incubator where a child simply waits to grow. It is an active environment, providing sensory inputs that physically alter how the brain wires itself. Cognitive and behavioral risks later in life occur when the sensory reality the brain receives severely mismatches the specific inputs it expects to build those neural networks. This timeline maps fetal brain development between 24 and 40 weeks. Notice the shrinking germinal matrix, the deep manufacturing center for new cells. Zooming in, neurons migrate outward, undergoing dendritic arborization, an explosive branching and connecting process to form the brain's circuitry. This wiring relies heavily on pre-myelinating oligodendrocytes. These are fragile glial cells responsible for laying down the central nervous system's white matter. When exposed to hypoxic or ischemic injury, these pre-myelinating cells fail to branch. They shrink and retract, destroying the structural integrity of the white matter. At the exact same time, the cerebellum is undergoing a massive parallel growth spurt, making it equally susceptible to environmental stressors. Because the brain is actively building its infrastructure during this window, external insults do not delay development. They inflict permanent structural damage to the white matter and cerebellum. To protect this fragile wiring process, fetal sensory systems are genetically programmed to develop in an absolute, strict sequence without overlapping. This biological hierarchy stack shows somatosensory and vestibular systems maturing first, driven by the amniotic sac's fluid boundaries. Once these base layers stabilize, chemoreceptive systems activate to detect smell and taste. Finally, auditory and visual systems mature last, remaining isolated prior to 30 weeks. If an infant receives out-of-sequence stimulation, like intense visual input before the eyes and ears are ready, it actively interferes with the maturation of the auditory system. The preterm brain is built to process exactly one new sensory modality at a time. Forcing it to process complex, competing stimuli disrupts the entire biological sequence. This split screen compares sensory environments. Left, the womb provides muted, slow-moving fluid waves. Right, the NICU delivers jagged, erratic spikes of light and sound data. When artificial lights hit undeveloped myopic eyes, the resulting neural overload visually fractures adjacent auditory pathways. The environment also introduces potent chemical odors, like the volatile vapors from alcohol-based hand sanitizers and specialized cleaning products. As these artificial vapors enter the delicate nasal cavity, they ignite a harsh, rapid electrical impulse along thick nerve endings. These volatile chemicals bypass normal olfactory processing. Instead, they overstimulate the trigeminal nerve subsystem, inducing a direct physical pain response. This trigeminal pain cascade rapidly alters cerebral hemodynamics, destabilizing the infant's heart rate and oxygen saturation. The routine medical interventions designed to maintain physical health are processed by the premature brain as structural assaults, miswiring the infant's sensory expectations. Because preterm infants lack mature autonomic control, standard physiological monitors only capture a fraction of their neurological distress. Clinicians rely on the synactive theory of development, a framework for translating the physical behaviors of an immature, nonverbal nervous system into actionable data. This diagram visualizes neurobehavioral capabilities as 4 interlocking gears: autonomic, motor, state, and attention. A sharp NICU stressor strikes the autonomic gear, causing it to stutter. This instability cascades, jamming the adjacent state and motor gears, grinding sleep regulation to a halt. Highly fragmented sleep cycles and jerky, uncoordinated motor movements are precise clinical biomarkers, proving the central nervous system is actively absorbing damage. Skin-to-skin contact is a primary medical intervention, a neuroprotective therapy that overrides the toxic sensory environment of the NICU. When an infant is placed in direct physical contact with an adult's chest, their physiology rapidly stabilizes. Mapping these physical points of contact between the parent and infant reveals a highly precise sensory delivery system. The parent's body delivers perfectly timed tactile, vestibular, and olfactory inputs into the infant's sensory nodes, matching the biological sequence we saw earlier. Simultaneously, the adult's body acts as a physical shield, dampening the intense, premature visual and auditory bombardment of the clinical ward. By utilizing skin-to-skin contact to restore the expected intrauterine sensory environment, we actively protect the premature brain's architecture. This ensures that keeping an infant alive ultimately translates into a thriving, healthy future.